All righty. Welcome, everybody, and good evening. Thanks for joining our men's health webinar. We're so excited to have the opportunity to share important men's health education with our group tonight. My name is Lee, and I am the host of tonight's evening. I'll start with a couple of quick housekeeping items, and then I'll introduce our speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your name or your face, and any questions you ask will only be seen by myself and the speaker. We encourage an interactive presentation, so if you'd like to ask a question, please type it in our chat box at the lower part of your screen. We'll save time at the end of the presentation to answer as many questions as possible. Tonight's webinar is presented by Dr. Daniel Box, a urologist and men's health specialist at Tennessee Valley Urology. Dr. Box, I know your time is in high demand, and I thank you for your willingness to be with us to share this education tonight to our community. I'll turn it over to you.
Thank you, Lee. Welcome, everybody. Thank you for joining me. Tonight, we'll be talking about two important topics in men's health that affects millions of guys across the United States: erectile dysfunction and male stress incontinence. My practice focus is on robotic surgery and male prosthetics. So these are two things that really hit home for my patients, and I'm happy to talk to you guys all tonight to give you some more information. Here's my background information. I work at Tennessee Valley Urology. I've been here for about 7 years now and really enjoy what I do. So we'll first start learning a little bit about what is erectile dysfunction. So ED is defined as the inability to achieve or maintain an erection that is firm enough for penetration for sexual intercourse. It's very common. Guys age 20 and older, about 1 in 5 or 20% suffer from some degree of ED. And as men age, men over 40, about half of guys have some degree of erectile dysfunction. How does an erection work? It is important to have good nerves and good blood supply in order to get a good erection. With arousal, the nerves around the penis become activated. Activation of those nerves causes the smooth muscle of the arteries to relax, which allows blood then to flow into the penis. That blood flow causes the penis to stiffen, and as the penis stiffens, the erection compresses the veins so that blood stays trapped in the penis and cannot leave, thus allowing the penis to remain erect. And this is the erect penis, and you can see the dilated, distended blood vessels causing the penis to be erect. There are many causes associated with erectile dysfunction. No single cause necessarily is the primary reason for it. And these causes are both physical and psychological. Risk factors include age and smoking, medical issues such as diabetes, high blood pressure, high cholesterol or triglycerides, depression, obesity, and a sedentary lifestyle. The chart on your right shows that about 3/4 of ED conditions are caused by either diabetes or a vascular problem. ED is also not just a medical issue. It can severely affect relationships and cause other mental health issues, depression being one of them. Getting into that, men who experience ED may experience anxiety, depression, low self-esteem, low self-confidence, a decrease in quality of life. And men with ED may withdraw from their relationships with people, both emotionally and physically. There are many conditions associated with ED, and we'll touch on them. ED and diabetes, very common. About half of men with diabetes have sexual troubles that's caused by their diabetes. Importantly, men with diabetes may be less responsive to oral medications to treat ED, and in some cases, ED may be the presenting symptom of diabetes. ED results in issues with the nerves and blood vessels, which we already mentioned are important to get an erection. As men age, diabetes can make it worse. The blood vessels and nerves can be damaged by high sugar or glucose levels. And ED medication, namely pills, requires stimulation and good nerve activity and healthy blood vessels in order to achieve the erection. If these are damaged due to diabetes, the pills may not work well. Factors that may increase ED in men with diabetes: advancing age, how long they've had their diabetes, how well their glucose levels are controlled with your A1C, underlying vascular disease, medications such as diuretics, and underlying heart disease. Heart disease also has a strong link with ED. Symptoms of heart disease may develop within 2 to 3 years of living with ED. ED is a risk factor for future heart-related events. And the severity of one's ED may be related to the severity of their heart disease. And in some cases, ED actually precedes coronary artery disease, or CAD, in about 3/4 of cases and could be a warning sign of heart disease. Heart disease and ED can be related. In fact, the two can be signs of the same disease process. The blood vessels that supply the blood to the penis, as you can see on that diagram, are very small compared to the blood supplying the heart or the carotid artery or the femoral artery. And so if those blood vessels become blocked due to underlying heart disease, it may not be possible to achieve good erection. Ways to reduce your risk, including improving your heart health through heart-healthy lifestyle choices, such as eating well, routine exercise and physical activity, weight loss, stopping smoking, limiting or avoiding alcohol, and avoiding illegal drugs, and taking steps in general to reduce stress. Testosterone and ED are also linked. Low T occurs when a man's body produces less testosterone than normal. It may affect people who are older, who have obesity, who have poorly controlled diabetes, have medical issues such as sleep apnea, chronic medical conditions like chronic kidney disease or liver cirrhosis, and patients who may be immunocompromised, such as those living with HIV and AIDS. The symptoms of low T are quite long and not necessarily specific always to low testosterone, but they can include a reduced sex drive, erectile dysfunction, loss of armpit or pubic hair, shrinking or smaller testicles, hot flashes, infertility or low sperm count, depression, difficulty with concentration, an increase in body fat, a decrease in lean muscle mass, among other conditions. There are many options that one can use to treat low testosterone, including injection therapy, patches, gels, and oral medication. Unfortunately, prostate cancer is very common, and the treatment effects are also very common in causing erectile dysfunction. When there is a procedure called a nerve-sparing procedure that, for men who are undergoing prostate cancer treatment, it may help them regain some level of erectile function, although it can take significant time to do so. The reason why prostate cancer treatment causes ED is because the nerves and blood vessels that supply blood to the penis to achieve an erection are very close to the prostate, and during surgery, those nerves and blood vessels can be injured. Prostate cancer can affect a man's ability to achieve an erection on either a temporary or more permanent basis. However, should ED persist, fortunately, there are treatment options. This diagram shows a prostatectomy. You have the prostate gland, the blood vessels and nerves are right next to the prostate gland. And so when the prostate is removed, unfortunately, those blood vessels and nerves can be injured, which results in erectile dysfunction. It is important to know your treatment options as there is hope for every man, nearly every man, living with ED. For men who undergo a nerve-sparing radical prostatectomy to treat prostate cancer, the percentage of ED is highly variable after surgery. Anywhere from 25 to 75% of men may experience some degree of ED. A lot of that depends on how one's function is before surgery, which will determine their function after surgery. Even with the best nerve-sparing prostate surgery, ED may persist for a year or more after that surgery. A condition called Peyronie's disease can also be linked with ED. Peyronie's disease is a disorder where scar tissue or plaque builds up in the penis. As you can see on this diagram, a fibrous plaque causes the penis to curve upwards. This can lead to a curve or bend up, down, or side to side, mostly during an erection. Peyronie's is benign, meaning it is not cancerous. However, it is a very common and bothersome condition for men. Patients may experience some inflammation and discomfort during erections or have the inability to perform intercourse due to the degree of curvature. There are several treatment options for Peyronie's disease. More or less invasive options would be oral medications or injectable medication that goes right into the plaque. There is surgery that can be done to remove the plaque. And then lastly, a great option for men is a penile implant, which can be a very good option for guys who have both erectile dysfunction and Peyronie's disease, allowing them to restore their sexual function. what you should know about ED and Peyronie's. A penile implant, which we'll talk about more soon, is a great option for men who are struggling with both ED and Peyronie's. During the procedure to address Peyronie's, a penile implant can be inserted to treat the ED. It is important to understand all of the risks and benefits, which we will talk about, and you should also talk about with your doctor. Now, the treatment options for ED. Who can treat erectile dysfunction? It is common for general practitioners or family doctors to be the first line in treatment of ED. Prescribing oral medications is the most common route that they do. Urologists are specialists in men's health, and we have more focused treatments beyond medication that we can offer. And then within urology, there's even another specialist called a prosthetic urologist or ED specialist who focuses on restoring men's sexual health with a penile implant procedure. ED treatment options include lifestyle changes and mental health support. That is step one. But then options to directly address the erectile dysfunction include oral medications or pills, a vacuum erection device, injection therapy, and lastly, a penile implant. Lifestyle changes and mental health support. We generally suggest that you would progress from a least invasive to most invasive option. Healthy lifestyle changes would include quitting smoking, losing weight, increasing physical activity, as these may help men regain sexual function or at least prevent it from getting worse. Psychotherapy can also be helpful for treating psychogenic ED when there are not so much underlying physical issues, but more psychological issues at play. Oral medications. There are a number of prescription medications that can be used. The way these work is by affecting the blood flow to the penis. When combined with sexual stimulation, this can help produce an erection. Side effects of the medication can include headache, facial flushing, or an upset stomach. It's important to consult with your doctor if you're taking other medications for heart or blood pressure, as these can interact. In a study of nearly 20,000 men with ED, men with diabetes were 1.5 to 2 times more likely to move on to other treatments beyond pills, such as a pump or penile implant, than men with diabetes. Diabetes is a huge risk factor for ED, and as we've said now and before, pills do not always work as well because pills require good blood flow and good nerve activity, and diabetes affects both of those. The next option is a vacuum erection device. This is a hollow plastic tube that is placed over the penis. There is a pump that pulls blood into the penis, and then once the erection is achieved, a small band is placed around the base of the penis to help maintain the erection. Side effects can include painful ejaculation, bruising, discomfort, pain, numbness, and coldness. It honestly is not a very popular treatment for my patients, just due to the restraints and discomfort of the device, but it is an option. And most common reasons for stopping this treatment are they're not able to achieve an adequate erection, or it is painful and discomforting when using the pump. The next option is injection therapy or intracavernosal injection therapy. With this, a needle is used to inject medication directly into the penis. The medication works at the source, allowing blood to flow into the penis, creating an erection. A small needle is used, an insulin-like needle is used, and it's attached to a syringe, and through that needle you would administer the medication. Most common side effects include penile pain at the injection site, a prolonged erection lasting longer than it should, the buildup of scar tissue, or a blood collection under the skin called a hematoma. Reasons for stopping the treatment: a poor response, loss of libido, inconvenient usage. It requires refrigeration. It is not always easy to go down to the kitchen, grab your medication, do the injection. It interrupts the process. So for that reason, it's very uncommon, or it's very common for men to stop this treatment. And then lastly, it can be cost prohibitive. Many studies have shown that withdrawal rates with injection therapy is relatively high. And lastly, a penile implant. A penile implant is a device that is implanted into the penis intended to allow a man with ED to have an erection. It is contained entirely in the body, concealed underneath the skin so that no one is able to see it, and it is controlled by the user to help achieve an erection. This is designed to allow for spontaneity, and the nice thing about the implant is that you can have an erection as long as you want, and it will not deactivate or go down until you press the button. 5 minutes, 50 minutes, that's what I tell patients, whatever they want, the implant will stay firm. Common side effects or complications of an implant would include postoperative pain or infection. Infection rate is very rare, but it is a serious and known side effect. Mechanical malfunction or failure. And lastly, erosion, where the tubing or implant material can erode through the skin. We'll go through several survey results, but the moral of the story with the surveys is that satisfaction rate is very high. In a survey of 80 patients who received the AMS 700 penile implant, 97% would recommend the implant to a friend. And you'll see those numbers are pretty consistent across multiple studies. This is the implant itself. It has several design options. There's a coating called inhibizone that is used to help reduce infection risk and the need for revision. The implant is designed to closely mimic a natural erection, and it provides rigidity when fully inflated. When it's deflated, it has a natural flaccid appearance. The implant has three parts: a reservoir that is tucked behind the abdominal muscle, these cylinders that go down the shaft of the penis, and a pump that sits in the scrotum next to or between the testicles. And again, everything is concealed underneath the skin. Implants have been in clinical use for 50 years, with over 500,000 being sold by Boston Scientific. This quick video will just show an illustration of how the implant works. So when the male wants to have an erection, the pump is squeezed several times. That causes fluid to go from the reservoir through the tubing and inflate the cylinders. The penis then stays hard until you press the deactivate button, which will cause the fluid to drain from the cylinders through the tubing back into the reservoir, and the penis will then remain in the flaccid state. What to expect from the procedure. This is typically done as an outpatient treatment option. It takes about 1 hour or so to do the surgery. It is done under anesthesia. Depending on the type of implant, the incision is either made above the penis, below the penis, near the scrotum, and typically the surgeon will insert all of the components through that one opening. As I said, this procedure is performed under general anesthesia. Several days of light activity after the procedure, and then you would return after having this done to start using the device as early as 3 weeks up to 6 weeks, depending on surgeon's preference. But the nice thing about the implant is you can go from having little to no erections to within a month being able to have a great erection whenever you want. Again, patient satisfaction. So in a survey of 194 patients, 95% reported satisfaction with intercourse, 95% were very satisfied or satisfied with their sexual activity, and 97% of patients would recommend a penile implant to their friend. So the patient's satisfaction rates, partner satisfaction rates are exceedingly high. And as you can see, most patients would recommend this and are very happy that they had this done. Cost is always an important part when deciding any treatment. Many commercial insurances will cover the diagnosis and medical necessity of ED. Medicare has a policy for ED which includes penile implants, but it is important to work with your doctor's office and insurance carriers to check coverage. And there may be financial assistance programs available to help cover any out-of-pocket cost. There are some known risks with the implant. As with any surgery, there are risks involved. One, not all patients are candidates for a penile implant. It's important to discuss with your doctor if you would be a candidate. But for those patients who are considering, important risks would include once you have an implant done, the ability to have a natural or spontaneous erection with any other treatment option is no longer possible. So pills, injections, vacuum pump, or spontaneous erection just cannot happen again after an implant is done. Device malfunction or failure leading to additional surgery can happen. Device migration, where it exposes through the tissue. Wearing away or loss of tissue. Infection, the incidence of infection is less than 1 to 2%. It's very uncommon, but it is a known risk of any kind of implant surgery, penile implant or other. And then lastly, unintended inflation of the device or long-term pain and soreness. ED is frustrating. It can be confusing, but we're here to help you. We encourage you to learn more about it. These options on the screen, you can scan the QR code, visit the ED Cure website. There are several patient testimonials there that you can read. Watch the docuseries Hard just to learn more about ED, or text the number listed to find more information. So that is the topic of ED. We will shift gears now to talk about stress incontinence, but if you do have any questions, please feel free to put those in the chat, and we will try to address them at the end. So male stress incontinence is our next topic. What is male stress incontinence? Stress incontinence occurs when movement or activity puts pressure on the bladder, which causes urine to leak. So, for example, coughing, laughing, jumping up and down, bending over to lift something heavy, and urine leaks out. It is very common. About 13 million men worldwide suffer from stress urinary incontinence. And in the United States, 17,000 men develop stress incontinence annually. The way that the urinary process works is the bladder stores urine. When the signal is sent from the brain to go pee, urine exits through the urethra. The sphincter is the muscle around the urethra, and normally the sphincter is in a closed state. The muscle is contracted. When the sphincter muscle relaxes, that allows urine then to exit the body from the bladder, down the urethra, and the penis. Causes and comorbidities with stress incontinence. The most common cause of stress incontinence in men is undergoing prostate cancer surgery, the prostatectomy. Surgery, radiation, or a combination of other therapies can affect the sphincter muscle and ultimately affect its functionality. Other causes, but less frequent, would be BPH surgery or surgery for benign prostate enlargement, underlying neurological or neurogenic conditions affecting the bladder or sphincter, prior pelvic surgery, prior urethral surgery, and as we mentioned, a radical prostatectomy. Stress urinary incontinence can significantly affect one's quality of life. Men with stress incontinence may have higher levels of depression than those without, and the odds of depression increases with increasing severity of one's incontinence. Around 90,000 radical prostatectomy surgeries are performed each year in the United States. At 1 year, 10 to 15% of men may have persistent leakage after surgery. And we have seen this diagram before, but this is important in understanding the mechanism of stress incontinence. In men, the prostate acts as a sphincter or valve, and you don't see it on this diagram, but there's also a skeletal muscle sphincter as well. When the prostate is removed, that valve or sphincter is no longer there. The external sphincter muscle can be injured during surgery, and once the urethra and bladder are connected back together, the only support around that area is the pelvic floor muscles. And those muscles, unfortunately, can take time to recover. And that is what we are hoping to help regain that functionality with time after surgery. But for men who don't gain that muscle function back, that is the situation that long-term incontinence can occur. There are many treatment options available, though, fortunately for us. And they include, again, kind of least invasive to most invasive, and we'll talk about all of those in good detail. Number one is just behavioral changes. The more you drink, the more you have to go pee. So naturally, if we limit our fluid intake a little bit, that can decrease the severity of one's incontinence. Also doing planned restroom breaks called timed voiding, where you go to the bathroom every 90 minutes to 2 hours, regardless of if you need to go pee. There are certain interventions that can be very helpful. Pelvic floor physical therapy is the mainstay of treatment for stress incontinence in men and in women. Doing Kegel exercises, which are the strengthening exercises for the pelvic floor muscles, and through a physical therapist or other mechanisms, one can also do biofeedback, which can add to the intervention process. And there are unfortunately coping mechanisms required to help with stress incontinence, ranging from pads to diapers, catheters, or even penile clamps. So let's talk about some of the more long-term treatment options for stress incontinence. These, as we mentioned here, work for many men in the short term and can help with long term, but for those patients who do require more definitive treatment, the patients that are in the 10 to 15% of incontinence still after surgery, there are ways that we can help them. So one option is something called an advanced XP male sling system. The intended benefit of the sling is that it is useful for men with mild to moderate stress incontinence, meaning they're wearing a few pads a day. They can more or less start or stop their flow, don't have a significant amount of leakage at night. There's a few other criteria, but a mild to moderate degree of incontinence. Doing a sling procedure is a minimally invasive procedure, um, and the sling works on its own to help restore continence. In one study, the reported reduction in pads was about 77%. This diagram shows the sling and the pelvic anatomy. The sling is this mesh piece of material here. This is the muscles around the urethra, and the sling is positioned right here underneath the urethra, and it acts as a hammock, which helps to lift and reposition and support the urethra. And in doing so, it helps to restore normal bladder control. About 90% of patients in a survey of 80 patients would recommend the male sling procedure to a friend. For those patients who would not be a good candidate for a sling or would want an alternative treatment option, there is the gold standard, which is the AMS 800 artificial urinary sphincter. This is designed to treat any degree of stress incontinence, and it is commonly used for those men with stress incontinence after prostate surgery. It is designed to discreetly restore the natural process of urinary control, and the AUS or artificial urinary sphincter mimics the function of a healthy urinary sphincter by closing off the urethra in order to stop the flow of urine and opening it when patients need or want to urinate on their own. Much like the penile implant, this is user operated. One important note with this, it does require good cognitive ability and good manual dexterity in order to use the device. This diagram shows the three parts of the artificial urinary sphincter. There's a control pump that sits in the scrotum next to the testicles, a cuff that is positioned around the urethra, and a pressure regulating balloon that sits behind the pubic bone. The artificial sphincter is filled with fluid and uses the fluid to open and close the cuff surrounding the urethra. When one urinates, the patient squeezes the pump. That pump releases fluid back into from the cuff into the regulating balloon. One empties the bladder, and then the cuff automatically refills with fluid after a few minutes. Once the cuff is filled, it squeezes the urethra closed to help prevent leakage. And this diagram or this video very well demonstrates it. At the moment, the cuff is in a closed position. The person will squeeze the pump. That causes fluid to drain from the cuff. The cuff opens up, opening the urethra, allowing one to urinate. Due to the nature of the pressure regulating balloon, after a few minutes, the cuff will automatically close again and return to its normal state, allowing the patient to achieve their continence. What to expect from the procedure? Much like with the penile implant or with the male sling, an AUS procedure is typically done as an outpatient. It is done under anesthesia. Small incisions, approximately 2 to 4 centimeters, are made. One in the perineum, which is the area underneath the scrotum, and then often another small incision above the pubic bone in the lower abdomen. And through those incisions, we are able to place all of the parts for the sphincter. Recommend a few days to a couple weeks of light, non-strenuous activity, and typically patients will be able to use their sphincter device about 4 to 6 weeks after the procedure was performed. Again, more patient satisfaction numbers. 90% of patients reported long-term satisfaction. 90+% would get the AMS 800 AUS would get the AMS 800 AUS again if given the option, and 94% would recommend it to friends or family. Long-term studies show that Most patients are using one pad or no pad per day after receiving the AUS. 85% at 4 years, 90%, 96% at 6 years, 90% at 5 years. So the long-term success rate of achieving continence or very close to continence is very high with this treatment. As with the implant, there are cost and coverage concerns. This is covered by Medicare and most private insurances when deemed medically necessary. Always work with your doctor's office and insurance carriers to check coverage. And as with any kind of procedure or product, there is no guarantee of insurance coverage, but we always work very closely with you and your insurance to try to get the coverage for this. Again, surgery has risks. Not all patients are candidates for the sling. Not all patients are candidates for the artificial urinary sphincter. It is important to discuss those options with your doctor, understand the risks and benefits, and determine what option might be best for you. Possible risks of a sling may include device failure, meaning that the incontinence persists despite the sling being present, developing urinary retention. If the sling is positioned too tightly, that can cause one to develop retention. Having post-op pain in the pelvic area from the mesh material and just from having the procedure done, and then irritation at the wound site. Regarding the artificial urinary sphincter, possible risk could include, much like with the penile implant, device malfunction or failure, which may require revision surgery in the future, erosion of the urethra in the area of the cuff just due to pressure over time on the urethra, patients developing urinary retention, and then finally, infection, pain, and soreness. It is important that you know that there are solutions for male bladder leakage. Unfortunately, men feel as though it is something that they just have to live with, either because that's what they've been told or just don't know the options that are out there. But there are great solutions for you. If you visit this website, fixincontinence.com, you can learn more about what we've discussed, scan the QR code, or visit that website. There's a symptom assessment questionnaire that you can take to learn how this may be affecting your life and what options there are for you. I really appreciate you joining us for this talk this evening. This is our information, Tennessee Valley Urology Center. I encourage you to call us, schedule an appointment if you have